Okay, thank you for the invitation. So the talk today will be about sepsis. And those are the objectives of the lecture. So we're going to review the sepsis bundles. We're going to price the studies that are the basis for the sepsis bundles. And we're going to appreciate how guidelines, recommendations may change in the near future. So this is the outline of my talk. We're going to start with the definition of sepsis, then the sepsis bundles. These bundles, they come from the guidelines, the sepsis guidelines that were published in 2013. And then we'll talk a little bit about lactate, talk a little bit of antibiotics and resuscitation fluids. Then we'll talk about the sepsis bundles that are supposed to be done within 6 hours. We'll talk a little bit about vasopressors, early goal-directed therapy, and then we're going to conclude our lecture. So this is the definition of sepsis. So probable or documented infection plus systemic manifestations of infection. So what are those? Fever, hypothermia, high heart rate, high respiratory rate, altered mental status, significant edema or positive fluid balance, high blood sugar, leukocytosis or leukopenia, or 10% or more bands, increased inflammatory markers, increased procalcitonin, arterial hypotension, organ dysfunction, and high lactate. And what is sepsis-induced hypotension? So it's sepsis plus a systolic blood pressure less than 90, mean arterial pressure less than 70, or systolic blood pressure decrease more than 40. So septic shock is defined as sepsis-induced hypotension persisting despite adequate fluid resuscitation. And then you have severe sepsis, which is sepsis plus organ dysfunction. So what are organ dysfunction? How can you evaluate whether there is organ dysfunction? So if you have a high lactate, if you have low urine output, if you have low oxygenation, if you have an increase in your creatinine level, if you have an increase in the bilirubin level, if you have low platelet count, or if you have coagulopathy. So those are signs of organ dysfunction, and severe sepsis is sepsis plus organ dysfunction. So those are the sepsis bundles that are supposed to be completed within 3 hours. So you want to get a lactate level. You want to obtain blood cultures prior to administration of antibiotics. You want to administer broad-spectrum antibiotics. And you want to provide IV fluid, 30 cc per kilo of crystalloid for hypotension, or if the lactate is over 4. So talk a little bit about lactate. So this was a clinical trial that was published in 2010 that looked at lactate clearance versus central venous oxygen saturation as goals for early sepsis therapy. This study was done here in the United States. So the hypothesis was to test whether there is no inferiority between lactate clearance and central venous oxygen saturation as goals of early sepsis resuscitation. So this was a multi-center randomized non-inferiority trial. So it was 3 centers in the United States. And they included patients with severe sepsis and evidence of hypoperfusion or septic shock admitted to the emergency department. So in the central venous oxygen saturation group, the patients were resuscitated to normalize the CVP, the mean arterial pressure, and to obtain a central venous oxygen saturation of at least 70%. On the other hand, in the lactate clearance group, the patients were resuscitated to normalize CVP, mean arterial pressure, and lactate clearance of at least 10%. The primary outcome was absolute in-hospital mortality rate, and the non-inferiority threshold was set at equal to minus 10%. So they basically wanted to see if lactate is equivalent to central venous oxygen saturation to guide your therapy in patients with sepsis. So they enrolled 300 patients, so not a very big study. And what they found was similar mortality. So the mortality in the group with lactate was 17%, and in the group that got central venous oxygen saturation to guide therapy was 23%. So similar mortality. So what the study tells us is that lactate is a good parameter, at least as good as central venous oxygen saturation, to guide your therapy guide how much fluid you want to give to the patient, etc. What about antibiotics? So when you are going to be managing someone with septic shock or severe sepsis in the emergency room, you want to provide the patient with broad-spectrum antibiotics. You want to tailor your antibiotic to the source of infection. I can tell you that most patients with sepsis, they have pneumonia, although a significant portion of these patients will have urinary tract infection, some will have intra-abdominal infection. And you want to tailor your antibiotic depending on the source of the infection. However, you want to start with broad-spectrum antibiotics. Those are very sick patients. You don't have a margin for error. So you actually want to err on the side of giving more broad-spectrum antibiotics at the beginning. And then as time goes by and you get the cultures, then you're going to de-escalate the antibiotics. Okay? But what I wanted to talk here is when to give antibiotic to these patients. The duration, from the time you recognize the patient has sepsis to the time the patient receives antibiotic. How can that impact the patient outcomes? So this was an interesting observational study that looked at duration of hypotension before initiation of effective antimicrobial therapy in patients with septic shock. So, again, observational study looked at the impact of delay of initiation of antimicrobials on outcomes. The count started from the initial onset of recurrent or persistent hypotension of septic shock. It included 14 ICUs and 10 hospitals in the US and Canada. It included more than 2,000 septic shock patients. And what they found is the longer it takes for you to provide antibiotic to a patient who has hypotension in the setting of sepsis, the higher the odds of mortality. And you see this very nice correlation here. So, effective antimicrobials within the first hour of documented hypotension, you got a survival of 80%. Each hour of delay, the survival decreased by 7.6%. So in this study, time of initiation of antimicrobial was the single strongest predictor of outcome in multivariate analysis. So the bottom line is if you recognize that someone has severe sepsis or septic shock, you want to make sure that patient receives antibiotic start as soon as possible. And you want to start to broad-spectrum antibiotics. Again, you're going to try to tailor more or less to the source of infection. In a substantial portion of patients, you will not know the source of infection at the beginning. But you want to err on the side of giving more broad-spectrum antibiotics early on. To be fair, there are other observational studies that looked at time to antibiotic administration outcomes that did not show this correlation. But I think it makes a lot of sense if you recognize someone has septic shock that you go ahead and try to get the antibiotic early on. Talk a little bit about resuscitation fluids. Basically, there are two types of resuscitation fluids that you can provide to your patient. There are colloids. Colloids are suspensions of molecules within a carrier solution. They are relatively incapable of crossing the capillary membrane, and they have a volume-sparing effect. So there is a 1:3 ratio of colloids to crystalloids. On the other hand, crystalloids are solutions of ions that are freely permeable. Concentrations of sodium chloride determine the tonicity of the fluid. So this slide is a little bit busy, comes from a review article published in the New England Journal of Medicine that I recommend you guys to take a look at. But basically it shows all the concentrations of ions in colloids and crystalloids and electrolytes. So you have within colloids you have albumin 4%, you have the starch, you have gelatin, and then you have the crystalloids, basically normal saline, lactate, ringer, and this balanced salt solution is called plasma light. We actually have here, but I'm told that this is expensive. So this was a study published in 2013 that compared albumin and saline for fluid resuscitation in the ICU. It was a multi-center randomized double-blind trial. And again, compared the effect of fluid resuscitation for albumin or saline on mortality. It included a heterogeneous population of patients in the ICU, so not only sepsis. And the primary outcome was death at 28 days. And the patients received either albumin 4% or normal saline. They enrolled almost 7,000 patients, so pretty big clinical trial. And what they found was that the mortality was similar in the group that got albumin, which was 20.9%, and in the group that got saline, which is 21.1%. So it was not, the difference was not significant. So they are equivalent, albumin and saline. So albumin is more expensive, therefore your fluid of choice should be a crystalloid. Now, in patients with traumatic brain injury, albumin was detrimental. So in these patients, there was an increase in the relative risk of death by 60%, and the photo was that albumin increased the intracranial pressure. So be aware that if you are dealing with a patient with traumatic brain injury, you want to avoid albumin. What about starch? Starch really has come out of use. There was a number of studies, clinical trials showing that the use of starch leads to increased rate of acute kidney injury and need for renal replacement therapy. So starch increased mortality as well by 90%, increased the risk of renal failure by 27%. So why is that? So starch solutions are effective volume expanders, but they are not localized to the circulatory system. They can deposit in the skin, liver, muscle, spleen, endothelial cells, and kidneys. So that's why perhaps this fluid is harmful. Now, just recently in 2012, there was an interesting study. It was not quite a clinical trial, it was a before and after type of study, where they compare chloride liberal versus chloride restrictive intravenous fluid administration. And they looked at kidney injury in critically ill patients. So again, there was a prospective open-label sequential period pilot study. And the hypothesis was to assess the association of a chloride restrictive versus chloride liberal intravenous fluid strategy with acute kidney injury in critical ill patients. So they included 760 patients in the control period, so chloride liberal, and 773 patients in the intervention period where there was chloride restrictive fluids. And the primary outcome was increased from baseline to peak creatinine level in the ICU and incidence of acute kidney injury. So what is chloride-rich solution? Chloride-rich solution will be saline, normal saline, will be 4% gelatin solution and 4% albumin solution. And what would be a chloride-restrictive solution? That would be lactate ringer, this balanced solution of plasma light, and chloride poor 20% albumin. Here is just showing the composition of the fluid. So with saline, you have 150 milliequivalents of sodium, 150 of chloride. With lactate ringer, you have 129 milliequivalents of sodium and 109 of chloride. With 4% gelatin, you have 154 milliequivalents of sodium and 120 of chloride. With plasma light, you have 140 of sodium and 98 of chloride. And with albumin 4%, you have 140 milliequivalents of sodium, 128 of chloride. And albumin 20%, then you have 48 to 100 milliequivalents of sodium and 19 of chloride. So in this study, there was the increase in the creatinine was lower in the patients who got chloride restrictive fluids. The incidence of acute kidney injury was lower in the patients who got chloride restrictive fluids, and the use of renal replacement therapy was also lower in the patients who got chloride restrictive fluids. So why is that? Why may chloride-rich solutions be detrimental? The chloride has a renal vasoconstrictive effect of tubular chloride reabsorption. So there is a renal vasoconstrictive effect of tubular chloride reabsorption. Greater chloride delivery to the macula dense may activate the tubulo-glomerular feedback, and that may lead to vasoconstriction, mesangial vasoconstriction, and reduction in GFR. So Chloride-restrictive solutions are more and more recommended for patients undergoing surgery, patients with trauma, and patients with diabetic ketoacidosis. So this study was provocative, but not definitive. And what are the risks of chloride-restrictive solutions? There are some risks as well. So they have lower sodium concentration, so they may result in metabolic alkalosis and hypotonicity. So you gotta be careful in patients who are hyponatremic, have alkalemia, have cerebral edema or traumatic brain injury. So in these patients, you gotta be careful using lactate ringer. So I'm sure there will be other studies looking into this. Now, looking at the bundles to be completed within 6 hours. So here you want to apply vasopressors for hypotension that does not respond to the initial resuscitation, and your goal is a MAP above 65. If you have persistent arterial hypotension despite fluid or initial lactate equal above 4, the bundles recommend to measure CVP and measure central venous oxygen saturation. And they also recommend to remeasure lactate if the initial lactate was elevated. So this is just a summary on a review article, kind of old but very interesting, looking at the effect of the different vasopressors on the receptors. And you can see here dobutamine basically has very little effect on alpha-1 and alpha-2, but a lot of effect on beta-1 and some effect on beta-2. Dopamine has some effect on alpha-1, no effect on alpha-2, a lot of effect on beta-1, some effect on beta-2, and of course has dopaminergic effect as well. Epinephrine basically has effect on all receptors except dopaminergic receptors. Norepinephrine also has effect on all receptors except the dopaminergic. And phenylephrine is predominantly alpha-1 agonist. So the norepinephrine levofed increases mean arterial pressure due to vasoconstrictive effects. It has little effect on heart rate and stroke volume. On the other hand, dopamine increases the mean arterial pressure and cardiac output primarily by an increase in the stroke volume and heart rate. So the question is, which ones we should use in patient septic shock, dopamine or norepinephrine? This was a systematic review that I participated on, where we looked into studies that had compared norepinephrine versus dopamine in critically ill patients with septic shock, or in a population that had predominantly sepsis as a cause of shock. So we included randomized clinical trials that compared norepinephrine with dopamine and reported 28-day or in-hospital mortality. And we pulled 6 studies. They are relatively small studies, except for this one here, the most recent one that was published in Europe, was done in Europe by the Baker. But basically, what this meta-analysis shows is that the use of norepinephrine leads to a decrease in mortality by 90%, although the confidence interval is kind of wide. It also leads to a decrease in arrhythmia, and that's pretty significant here. So norepinephrine, as compared to dopamine, leads to lower mortality, less arrhythmia. Dopamine may also influence the endocrine response via the hypothalamic pituitary axis and have immunosuppressive effects. So the bottom line is norepinephrine should be a vasopressor of choice, particularly when you are comparing with dopamine. What about epinephrine? So the guidelines say that epinephrine should be the first alternative to norepinephrine. This is interesting because we don't always think of epinephrine. So human and animal studies suggest that epinephrine has deleterious effects on the splanchnic circulation and produces high lactate. However, there are 4 clinical trials comparing norepinephrine with epinephrine, and there was no evidence for difference in risk of death. So here's what the guidelines say. I'm quoting the guidelines. We suggest epinephrine added to and potentially substituted for norepinephrine when an additional agent is needed to maintain adequate blood pressure. It's a great to be. Bottom line is what they're saying is if you're maxing out on norepinephrine, you still need another depressor, go ahead and initiate epinephrine and potentially even replace the norepinephrine with epinephrine. What about vasopressin? We use a lot of vasopressin as the second vasopressor of choice, but does the evidence really back that? Do we have data that shows that this is a good thing to do? So this is a clinical trial that was published in 2008, vasopressin versus norepinephrine infusion in patients with septic shock. It was a multi-center randomized double-blind trial. So the hypothesis was that low-dose vasopressin, as compared with norepinephrine, would decrease mortality among patients with septic shock. So they included patients who had septic shock and were already receiving a minimum of 5 micrograms per minute of norepinephrine. And then those patients were randomized to add low-dose vasopressin, so they would add to the vasopressin the patient was already receiving, or just titration of norepinephrine. And so the study included 396 patients that received vasopressin and 382 patients that received norepinephrine. And there was no significant difference between vasopressin and norepinephrine groups in 28-day mortality. So it was a neutral study, didn't show any difference in mortality. However, there was a priori analysis looking at the patients who were less sick. The patients who were receiving 15 or less of norepinephrine. And in those patients, paradoxically, vasopressin led to improvement in survival. So pretty much what this study tells us is that if you have a patient on liver fat and the patient is not requiring a high dose of liver fat, it's probably beneficial to add vasopressin. But if you have a patient on norepinephrine and the dose of norepinephrine is high, it will not be beneficial to add vasopressin. And I think it's interesting to go over this study because we do pretty much the opposite a lot of times, right? So when the dose of liver fat is being maxed out, we add vasopressin. But that's not what the evidence tells you to do. So here's what the guidelines recommend. Vasopressin, up to 0.03 units per minute, can be added to norepinephrine with the intent of raising MAP to target or decreasing norepinephrine dose. But it was ungraded recommendation. What about phenylephrine? So phenylephrine has almost pure alpha-adrenergic effect. So this adrenergic agent is the one that is least likely to produce tachycardia. It may, however, decrease stroke volume. It's not recommended for routine use in septic shock, but you can consider in the following situations: serious arrhythmias, cardiac output known to be high, and as salvage therapy. What about inotropic therapy? So the guidelines recommend that a trial of dobutamine infusion up to 20 micrograms per kilo per minute be administered or added to vasopressin in the presence of myocardial dysfunction or ongoing signs of hypoperfusion despite achieving adequate intravascular volume and adequate mean arterial pressure. So there was no reference that I could see for those recommendations, but they recommend in case of myocardial dysfunction. They recommend against the use of a strategy to increase the cardiac index to predetermined supranormal levels. Okay, so what about those two recommendations here for the 6 hours bundle? Measurement of central venous pressure and measurement of central venous oxygen saturation. We'll talk a little bit about that. Those two components are part of what we call early goal-directed therapy. So before we go over, let's just remind. So what is arterial oxygen content is dependent on the oxygen, on the amount of oxygen bound to hemoglobin and the amount of oxygen dissolved in the blood. Mixed venous blood oxygen content is pretty much the amount of mixed venous oxygen saturation bound to hemoglobin and the amount of mixed venous oxygen dissolved in the blood. And oxygen delivery is the arterial oxygen content times cardiac output. And oxygen consumption is the cardiac output times the difference between the arterial oxygen content minus the mixed venous oxygen content. So, in a normal person, as the oxygen delivery decreases, the oxygen consumption remains relatively constant up to a certain point, at which point the oxygen consumption starts to decrease. But this is not true in patients with sepsis. In patients with sepsis, as the oxygen delivery decreases, the oxygen consumption starts decreasing right away. Back in the 80s, there were some observational studies, and there was this observational study in particular that showed that in patients with sepsis, septic shock, or sepsis, who survive, the oxygen delivery tends to be higher than the patients who do not survive in the hours preceding the hypotension. And the oxygen consumption tends to be higher as well in patients who survive as compared to patients who do not survive. Therefore, it makes sense to try to increase, it makes sense from a physiological standpoint to try to increase the oxygen delivery to patients with sepsis. And so you can use, for instance, the mixed venous oxygen saturation, which reflects the balance between oxygen delivery and oxygen consumption. You can monitor that, and you can try to target a normal mixed venous oxygen saturation, more than 70%. And how can you increase the oxygen delivery of these patients? Basically, by increasing the cardiac output, and you can also, which is a very effective way of increasing the oxygen delivery, by blood transfusion. So, in order to increase the cardiac output, you can put a patient on inotropic agents or vasopressors, or you can also give IV fluid, and you can kind of tailor how much of IV fluid you're going to give to the patient according to the CVP. So if the CVP is low, you know that the patient is the ascending portion of the Frank-Starling curve, and the patient will likely improve their cardiac output by receiving IV fluid. So in the early 2000s, there was this clinical trial, early goal-directed therapy in the treatment of severe sepsis and septic shock. This was a single-center study done in Detroit. And the purpose was to evaluate the efficacy of early goal-directed therapy before admission to the ICU. So in the first 6 hours. Because before this study, there are a number of studies done in the ICU that had looked at goal-directed therapy and had not shown a survival benefit. But this study was different in that it looked right when the patients came to the emergency room, the first 6 hours. And the primary outcome was in-hospital mortality. And again, this was a single-center study. It enrolled only 263 patients. And basically, this is to show the randomization process. And so the patients who got into early goal-directed therapy, they would have CVP, they would have central venous oxygen saturation, they would look at the urine output, they would look at the hematocrit, and so on and so forth. Whereas the patient who got standard care, they would only look at the CVP, the mean arterial pressure, the urine output. So this is what the early goal-directed therapy was. So the patient, so you had a patient who came to the emergency room with sepsis, and you'd measure the CVP. And if the CVP was less than 8, you'd give crystalloid or colloid. And then you'd look at the mean arterial pressure, and if the mean arterial pressure was less than 65, they would get vasopressors. And then you'd look at the central venous oxygen saturation. And if the central venous oxygen saturation was less than 70, remember, they want to improve the oxygen delivery. They would get blood transfusion to keep the hematocrit above 30%. And if despite that, the central venous oxygen saturation was less than 70, they would get inotropic agents. And that's what the early goal-directed therapy consisted of. And this study actually showed a marked improvement in survival in patients who received the early goal-directed therapy. So mortality was 30.5% in the patients who received early goal-directed therapy versus 46.5% in the patients who got usual standard care. So this study it basically changed practice throughout the world. People started getting central lines, a patient who had sepsis, no matter what, and people start measuring the central venous oxygen saturation of these folks. and even transfusing blood for some of these patients in the ER. But then, again, this was a single-center study, and so all the investigators tried to replicate this study. So there was 3 large clinical trials, one done here in the US, one done in England, and one done in Australia. So we're going to go over. So the first one is this one, goal-directed resuscitation for patients with early septic shock. So 51 centers, mostly in Australia, New Zealand. Patients in emergency department were assigned to early goal-directed therapy or usual care. Primary outcome was all-cause mortality within 90 days. It enrolled 1,600 patients, and the mortality was the same in early goal-directed therapy versus control. Then there was this study called a randomized trial of protocol-based care for early septic shock. This was done here in the United States, 31 emergency rooms. So patients would be randomized to protocol-based early goal-directed therapy, protocol-based standard therapy, or usual care. The primary endpoint was 60-day in-hospital mortality. And again, the mortality was the same. There was no statistically significant difference in the 3 groups. Then there was this study, trial of early goal-directed resuscitation for septic shock, and 56 hospitals in England. And again, early goal-directed therapy versus usual care. Primary outcome was all-cause mortality at 90 days. More than 1,000 patients enrolled. And again, mortality was the same. So pretty much those findings were not replicated. And this is finally a meta-analysis showing that there was no survival benefit with early goal-directed therapy. So this is just to show that despite the fact that there was no mortality benefit, it's important to realize that the amount of fluid that these patients got was kind of similar. For instance, in this study here, the early goal-directed therapy got 2.8 liters, and the control group got 2.7 liters. In this study here, the early goal-directed therapy got 1.9 liter. This is the first 6 hours, okay? And the control group got 1.7 liter. And this one, the early goal-directed therapy got 2.2 liters, and the control group got 2 liters. So they received more or less the same amount of fluids, okay? The amount of vasopressor therapy was kind of similar as well. So you can see here 55 versus 48, 66 versus 57, 53 versus 46. What the early goal-directed therapy received more was dobutamine, okay? And they received more blood transfusion. So what I'm trying to say here is that maybe with the RIVER study, people realized that it's important to resuscitate these patients vigorously in the first 6 hours. And because of that, we already know that, you know, if you go to the emergency room and you provide antibiotic early on, you give fluids early on, you improve the outcomes of the patients. So that's why maybe there is no difference in mortality, because patients are getting more or less the same amount of IV fluids and everything else. But then with these studies, this is an update from the Surviving Sepsis campaign, and I'm going to just read what they wrote here. So, required monitoring of CVP and central venous oxygen saturation via central venous catheter as part of an early resuscitation strategy does not confer survival benefit in all patients with septic shock who have received timely antibiotics and fluid resuscitation compared with controls. So requiring measurement of CVP and central venous oxygen saturation in all patients who have lactate more than 4 and all persistent hypotension after initial fluid challenge and who have received timely antibiotic is not supported by the available scientific evidence. So the results of these 2 trials have not demonstrated also any adverse outcomes. So they basically, even though it doesn't improve survival, it also doesn't worsen outcomes. Therefore, they're keeping the bundle, but they are leaving up to the physician to decide whether to go ahead and get a CVP and get central venous oxygen saturation. So again, this is just to conclude. So the bundle within 3 hours hasn't changed. So you're going to measure lactate, you're going to get blood cultures, you want to administer broad-spectrum antibiotics, you want to give 30 cc per kilo of crystalloid for hypotension lactates above 4. Now, the bundle for 6 hours now has changed, okay? So I'm just reading here what was the bundle initially. So apply vasopressor to maintain mean arterial pressure above 65. In the event of persistent arterial hypotension despite volume resuscitation or initial lactate more than 4, that was the recommendation, measure CVP, measure central venous oxygen saturation. And then another recommendation was re-measure lactate. Now, this is what changed, okay? So in the new recommendations, in the event of persistent arterial hypotension despite volume resuscitation or initial lactate more than 4, you want to do a physical examination looking at vital signs, cardiopulmonary capillary refill, pulse, skin findings, and then they leave up to you to decide whether to get a CVP, central venous oxygen saturation, bedside cardiovascular ultrasound, or dynamic assessment of fluid responsiveness with passive leg raise or fluid challenge.